Yeah.
Okay. So don't hit the X buttons, and you can just hit your live stream, and I'll put you on over there. Hi, everyone. Sorry about the delay. We just had a little bit of technical difficulties. We'll get started in a few more minutes just to let everybody fully log on. And we are just going to give it one more minute. Hello, everyone, and thank you for joining us today on a joint effort, What to Know When Considering Knee Replacement. With me today is Dr. Jahng. Please note that this virtual community lecture is being recorded and live streamed. Also, please make sure to save all questions until the end of the lecture and make sure to use the Q&A and not the chat. Kathleen, would you like to introduce yourself?
Yes, so my name is Kathleen Webster and I'm San Antonio Regional Hospital's orthopedic nurse navigator. My function as a navigator is to assist orthopedic patients throughout the continuum of their care here at San Antonio. And before I introduce you to Dr. Jahng, I'd like to highlight a few things about our award-winning joint replacement center. We perform over 500 total hip and knee replacement procedures every year. And we have a dedicated orthopedic nursing unit for total joint replacement patients, all with private rooms. Our patient satisfaction scores exceed the top 10 percentile in the nation. And we have consistently achieved the Joint Commission's advanced certification in total hip and knee replacement since 2017. Our success can be attributed to a team effort between our nursing and physical therapy staff, surgery staff, and orthopedic surgeons, offices, and surgeons such as Dr. Kenneth Jahng. And Dr. Jahng has been on staff here at San Antonio since 2015. And he, excuse me, he is the medical director of the hospital's Orthopedic Institute. He's a native of the Inland Empire, having grown up in Riverside and Loma Linda areas. He attended Riverside Poly High School and went on to earn a Bachelor of Science degree in both business administration and chemistry at Pacific Union College, where he graduated magna cum laude. He received his MD from the Loma Linda University School of Medicine and completed his residency training in orthopedic surgery at Loma Linda University Medical Center. Dr. Jahng also received subspecialty training in adult hip and knee construction at Lenox Hill Hospital in New York City. There he gained wide exposure to a wide variety of joint replacement surgeries, including direct anterior approach hip replacement, partial knee replacements, and other complex hip and knee replacement procedures. He has also participated in several academic endeavors, including studies regarding direct anterior hip replacement and its potential complications. Dr. Jahng is an assistant clinical professor associated with Loma Linda University. In his spare time, Dr. Jahng enjoys spending time with his wife and daughters, family, and friends. He also enjoys various outdoor activities, including surfing. And now I'd like to present to you Dr. Kenneth Jahng.
Hello, hi, I'm Kenneth Jahng. Thanks for joining us. And thank you, Kathleen, for that nice introduction. And we'll go ahead and get started here. So first, I want to apologize for the little delay. I have to admit that's my fault. I sat in front of this computer and just started hitting buttons and accidentally closed out the Zoom presentation. But yeah, the title of this presentation is A Joint Effort, What to Know When Considering a Knee Replacement. And I feel like this is a very appropriate title because it really is a joint or team effort in doing these procedures successfully, and we'll get into that. So as Kathleen had already mentioned, I did a lot of my training over at Loma Linda with medical school and my orthopedic residency. I did my fellowship in hip and knee reconstruction in New York City. And I've been working with ARROWHEAD Orthopedics and at San Antonio Regional Hospital for the last 7 years. And I also work with some of the residents at the Loma Linda University residency program through ARROWHEAD Regional Medical Center. Again, I'm with the ARROWHEAD Orthopedics group. We're one of the largest orthopedics group in Southern California. We have 30 surgeons with all subspecialties. There are 10 locations scattered over the Inland Empire. And we provide care for orthopedics, workers' compensation, pain management, and physical and occupational therapies. So many of you know about San Antonio Regional Hospital. It's been a member of the community since 1907, and they've had a certification from the Joint Commission with the gold seal of approval for total hip and knee replacements. And this is a advanced certification. And what this means is they recognize that the hospital program is in compliance with consensus-based national results. They effectively use evidence-based clinical practice guidelines to manage and optimize care. And they also take an organized approach to performance measurement and improvement activities. And just being a part of the program and seeing how all my patients have done and their reviews, I can tell you that it's a very good program. So we're talking about knee replacements or knee arthroplasty. And so what is a knee arthroplasty? The word arthroplasty has a Greek origin from two words, arthron and plastos. Arthron meaning joint and plastos meaning formed or molded. And here's a picture of Martha Stewart and Snoop Dogg, and they know a little bit about molding or forming joints, but that's not the kind of joint we're talking about this evening. We're talking about the knee replacement. So why do we do a knee replacement? Basically, it's for end stage arthritis. And there's various types of arthritis. And here's a few examples. The most common is going to be osteoarthritis. It's that just kind of cumulative wear and tear of the cartilage surface that degrades that joint surface. Another type of arthritis is inflammatory arthritis, which is an autoimmune disease like rheumatoid arthritis, where the whole joint is affected. And that is illustrated here in the middle picture or a middle x-ray. And another big type of arthritis is your post-traumatic arthritis. And that's when an individual has had some kind of trauma to the joint surface, plus or minus a surgery, and later that joint surface and that cartilage has worn down. So again, arthritis is when the cartilage surface is worn down. And you can have both mechanical and inflammatory symptoms from that. The cartilage, again, acts like a cushioning for the knee joint. So once it's worn down, it'll reveal the underlying bone, and that can cause a mechanical grinding and pain. But in addition to that, your body can respond with symptoms of inflammation. And classically in medical school, we're taught the symptoms of inflammation include rubor or redness, calor, heat, tumor is swelling, and dolor is pain. And when it comes to the knee joint or the knee, it's comprised of three bones, the lower end of the femur, the upper end of the tibia, as well as your patella or kneecap. And within the knee, there are three cartilage compartments. One being the anterior compartment, that's right underneath the kneecap, the medial compartment, which is on the inside of your knee, and the lateral compartment, which is on the outer side of the knee. So again, some symptoms of arthritis are pain, swelling, instability, loss of motion. And so those are all physical symptoms, but it can also take a psychological toll on a person as well. So some of the non-surgical or conservative types of treatment include lifestyle modifications, or which is essentially not doing things that aggravate your pain or other symptoms. Medications, including a lot of over-the-counter medications like ibuprofen or Tylenol. Weight loss can always be helpful. Exercise is good for the body overall, and you want to stick with low-impact exercises to avoid the trauma to that worn down joint surface. Assistive devices, including braces and canes, can be helpful. And there's a few different types of injections that we'll be talking about. So here are various injections that people will have. Corticosteroid or a steroid injection is going to be the most common type of injection, and that provides anti-inflammation to the knee joint. And that's going to be, again, the most common one and the least expensive one. Another common one that's done is hyaluronic acid, or the gel shots, or as some people say, the rooster shots. And that's supposed to provide added lubrication to the knee joint. That injection may or may not be covered by one's insurance. And the other two injections here are often not covered by insurances, and those include PRP, or platelet-rich plasma, and then also the stem cells. The PRP injections, how it's done is blood is drawn from a person's body and then spun down in a centrifuge. And so that there are healing and growth factors that are concentrated into a smaller volume, and those are injected back into the joint. And the theory behind stem cells is that you take some immature cells from various areas of the body, and those are the immature cells, and you put them into the joint, and they will differentiate into new tissue and release growth factors. This type of injection is the most costly, and it's not covered by insurance, to my knowledge. And there's not a lot of evidence that shows that it actually does what it's supposed to do. It does not regrow cartilage in a worn down joint. I think there's still a lot of research that needs to be done for stem cells, and hopefully in the future we may have promising results. And excuse me, for all these different types of injections, they do help with inflammation, but unfortunately, they do not regrow or regenerate any of the tissue or the cartilage. So of all those treatment options we discussed, these are the recommended treatments from the American Academy of Orthopedic Surgeons. And this is these guidelines were updated in August of this year. And all the recommended treatments are supported by moderate to high level studies that were reviewed. And so the recommended treatment options include canes and braces, over-the-counter medications, including anti-inflammatory or non-steroidal anti-inflammatory drugs, acetaminophen or Tylenol, low-impact exercises and weight loss, and also corticosteroid injections for short-term pain relief. Treatment options that are not recommended are narcotic pain medications for chronic pain, from arthritis, the hyaluronic acid or gel injections, as well as knee arthroscopy. So moving on to different types of surgical treatment, these include arthroscopy, osteotomy, as well as the partial or total knee replacement. The knee arthroscopy is designed, well, it can be done to treat a meniscus tear that is associated with arthritis, but it does not treat the arthritis itself. Again, arthritis is wearing down of that joint or chondral surface. And when you do knee arthroscopic surgery, that will not regenerate any of that worn down cartilage. And osteotomy is essentially cutting the bone. And you can do this to realign the bone so that the forces across the joint surface are more evenly distributed. And this can be done for early arthritis. It's not as common these days, as they have inferior results compared to the knee replacements. The partial knee replacement is done if only one compartment, that's one of the three compartments of the knee, is affected. But if there's two or three compartments that are affected, then a total knee replacement is going to be the appropriate surgery. This is an example of the partial or unicompartmental knee replacement. Again, this is done when the arthritis is limited to just one compartment. The advantages to doing this is that it's less invasive, so a faster recovery, and more of the anatomy is preserved, so more of the normal kinematics of the knee are also preserved. Disadvantages, or the disadvantage to doing this, is that the arthritis can progress to the other compartments, and a person may need to have another surgery to convert that to a full knee replacement in the future. So again, the total knee replacement is done when two or three compartments are affected. And here's an example of the different implants that are used in the knee replacement. There's the femoral component, which is the top portion, the tibial component, which is the bottom, and there's the polyethylene or plastic piece that sits in between them and acts like the new cartilage in the knee joint. And there's also another plastic kneecap component, which is not illustrated here. The goals of a total knee replacement is to decrease pain and inflammation in that worn down joint, to improve function and endurance. We can also restore limb alignment when we do the total knee replacement. We also want to add soft tissue stability and also provide better tracking of the patella or the kneecap. So there's various types of implants that can be used in knee replacements. These include cruciate retaining or posterior stabilized polyethylene components or the plastic piece. There's also fixed bearing and rotating platform polyethylene components. Most of the knee replacements are made of metal, but there's also non-metal type of components. The gender-specific components are supposed to be fitted for males and females, and there's traditional versus patient-specific instruments that can be used. However, despite some of the manufacturer claims, registry data doesn't show that there are really superior advantages to any specific types of components. So there are also some newer technologies that are being used with knee replacements. And I say newer because these have actually been around and been used for quite some time, but they're still being improved. And they include patient-specific instrumentation, navigation, as well as robotic surgery. The goals for these newer technologies is to improve alignment as well as component position. However, a lot of these technologies add a cost, and also the studies don't show that they actually have superior or better results. So patient-specific instrumentation is done to improve alignment of some of the cuts that are made during surgery. This involves getting a CT scan or MRI prior to surgery in order to make these plans, and also to create these customized cutting molds that fit onto the bone during surgery. They can be helpful when there are some deformities in the bones. For example, when somebody has had a prior trauma, or if there are retained implants that are getting in the way of the traditional instruments that are used. So it does add an extra cost, but the results are not actually superior to the traditional instruments. But it's another tool that can be helpful in doing these surgeries, but not universally for everybody. And I just have a couple examples of good review studies, some systematic review and meta-analysis of the PSI, and it shows that it doesn't actually give superior results. Navigation is another technology that's being used. It can be computer based or accelerometer based, which does not use a computer. Again, this is used to improve overall alignment of the cuts and as well as the overall leg. There is also conflicting evidence of if this has better outcomes. It does increase some of the surgery time, especially early on in the learning curve. But again, the outcomes are not superior simply by using this technology. As Many of you have probably heard more about robots or robotic type of surgery, and this is also being done in orthopedics. Essentially, for the knee replacements, a robotic arm is used to assist in making some bony cuts. It does, or it can improve accuracy and precision in making these cuts. However, there is a learning curve to using this, and it can increase surgical time. One big downside I see to it is that you're really limited in using in the type of implants to use, because every implant company has their own type of robot, which is very costly. And so if the hospital purchase a robot, they are committed to using only those type of implants. Again, it's another tool that can be helpful in a successful surgery. However, results don't show universally that outcomes are better, or that implant survivorship is better, or there are less complications. One big improvement in these knee replacements has been the way that we approach anesthesia, and that is with a multimodal approach. Back when I was in training, patients would be given a lot of narcotic medications. They'd be in the hospital for a week, and they would go to a nursing home for 2 to 3 weeks. So it was a very long, drawn out process. However, now with the multimodal approach, a lot has changed. And with that multimodal approach, we try to address the various levels of pain that people experience, because a person can experience pain at the site of the surgery or trauma, but they also feel pain along their peripheral nerves, their spinal cord, as well as their brain. So when it comes to these surgeries, medications can be given prior to surgery. Also, MAC anesthesia, or monitored anesthesia care, is done, or a light general. We often do spinal blocks to help with pain control, as well as control some of the bleeding during surgery. Peripheral nerve blocks can also help with pain management. During the surgery, I will also do a periarticular injection, which is injecting the joint capsule and soft tissues with some medication. And also with the postoperative medications, we now give various medications to, again, address the different levels that people feel pain. So nowadays, the recovery process is much different and much better. Again, before, the length of stay in the hospital 10, 15 years ago seemed to be a week, but now often these are done on an outpatient basis, or you stay in the hospital 1 or 2 days. Early mobilization has really helped for this, and also aggressive motion. I always tell my patients that early on in the recovery process, regaining that range of motion is very important, and you want to do that before that scar tissue starts setting in, because that can really restrict your motion for the rest of your life. We used to use these CPM machines to help a person bend their knee. However, there have been a lot of studies over the years which showed that it actually doesn't help, and we've actually abandoned use of these machines. Most people are able to recover at home, but they do need that social support or coach to help and assist them. Outpatient physical therapy, I think, is very important to do, but also doing the physical therapy on your own at home is just as important, if not more important. Typically, the length of recovery is 3 months for most activities, but it may take 6 to 12 months for full recovery and maximum strength. So after knee replacement, the vast majority of people are better. They have less pain and improved function. However, they can still have a small amount of residual pain, stiffness, and swelling. And we've, and the orthopedic community has identified some risk factors that can contribute to this, including having the surgery done when the arthritis is not that severe, as well as having lower preoperative function or health, as well as having suboptimized mental health issues such as depression. So again, it's important to try to optimize these comorbidities. And you typically, again, don't want to have these surgeries done until the arthritis is pretty severe. So previously, we used to tell patients that the knee replacement would last maybe 10 years and they would have to have another surgery. But now we hope that that would be, that's 20 years or longer. And that has to do with improvements of the implants that we use, and specifically that plastic polyethylene component. But you can also estimate the failure rates by 0.5 to 1% annually. So that means at 10 years, we anticipate a 90 to 95% survivorship of these implants, or at 20 years, 80 to 85% survivorship. So unfortunately, there is a dark side to knee replacements, and complications can happen. Specifically for the knee, people can still have some pain afterward, some swelling. They can have infections or knee stiffness or instability and loosening of the component. And there's also general health complications that can occur, including blood clots, nausea, heart attack, stroke. And obviously, we want to avoid all these complications. And so optimizing one's health prior to surgery is helpful for this as well. And the orthopedic community has also identified risk factors that can increase the chance for some of these complications. And these are broken down into modifiable and non-modifiable risk factors. The non-modifiable ones include things that you can't really change, like somebody's age, or if they've had previous surgery. But for the modifiable ones, you want to try to optimize those as best possible prior to the surgery. So here's just a couple pictures and videos of how I do a knee replacement surgery. And so here I've already opened up the knee joint. I'm making a distal femoral cut, or cutting the bone that's of the bottom half of the femur. And I'm making a flat surface there using the cutting guide. And here the tibia, or the bottom portion of the knee, or the upper portion of the tibia, is exposed. And I'm making a flat cut here as well. Again, we're cutting off the worn down joint surfaces. So after I've made those cuts, I want to balance this space with the knee in full extension. So I have the knee fully straight. I have this spacer block in between the bony cuts, and I want to make sure that's a nice rectangular gap, and it's stable when I stress it back and forth. And I want to be able to have that knee fully straight. Here I'm now assessing and balancing the flexion gap. I want to create another rectangular space that is exactly the same size as my extension gap. And so these are some instruments that I use in order to make that assessment. And once I do that, I can make the rest of After that's done, I place components. First, I put the trial components, and then I'm making an assessment of the knee joint. And I want to be able to get the knee fully straight, and I want to be able to have deep flexion, and I want it to be stable to when I stress it back and forth throughout the motion. Also, when I stress it back and forth. So these are the components. These are the trial components I have in, and I want this knee to be nice and stable. And then I'll take those trial components out, put the final components in, and I also want to make the same assessment, make sure that it's moving and just as stable as the knee was with the trial components. So if you're thinking about having surgery, the things you want to look at is if you have that end stage type of arthritis where the chondral surface is totally worn down. You've tried all non-surgical types of treatment. However, they haven't given the relief that you're hoping for. Again, medical optimization is very important. And you have to be ready and be committed to that post-operative recovery process because it can be lengthy. But ultimately, the choice is up to you if you want to do it, but you should have that discussion with your surgeon as well. All right, well, that's it.
Wow, that was a very informative presentation. Do you want to go ahead and stop sharing your screen because there are a few questions that the participants have?
Sure. Mark asked, why is gel injection not approved for knees, and does it cause complications in knee replacement surgery?
The gel injection, sometimes it's approved by insurances. I mean, they'll agree to pay for it. Sometimes they won't. There have been studies on the efficacy of the gel shots. Some support them, some do not. So overall, there is an overwhelming evidence that says that it actually makes a big difference. So that's why the American Academy of Orthopedic Surgeons doesn't support its use. Anecdotally, it can help some patients. I have a number of patients that it really helps. So I'm okay using it if it does help them.
So would it cause any complications if the patient decided to have a knee replacement after having the gel injections, or
No.
would they have to wait a certain amount of time?
Yeah, not to my knowledge, I don't think that it would cause any complications if you're considering doing a knee replacement surgery.
Thank you.
And how many inches is the scar from the surgery?
Really, it depends on the necessary exposure. So it can really vary just based on how big the person's knee is or how bad the arthritis is. I tell all my patients, make that incision as big as I need to in order to get the appropriate exposure, make the appropriate assessments, and put components in the correct way.
And Arlene asked, how soon can you drive after right
down here
knee surgery?
It's a good question. Yeah, especially, if you're, I guess I was going to say if you're driving automatically, you need to use your right leg.
Yeah.
But usually I tell people it's going to be probably about a month, if not more. There have been some studies that look at return driving after just a right lower extremity surgery, and that could be anywhere from 6 to 9 weeks. So I tell people, what's really important is safety and having that reaction to hit the brakes when you need to. So, if you feel well, strong, not having too much pain, yeah, you can probably drive a little bit sooner than the person that may be having a little bit more pain.
And Arlene also asked, can you kneel down and get up easily after healing, or are your kneeling actions limited?
Yeah, I mean, hopefully you can, but kneeling is probably one of the hardest things to do after knee replacement. Yeah, kneeling on the knee can be problematic and painful for some people, but not everybody. You know, with the kneecap itself is a small bone, and we cut a little bit of that bone to put the patella component on, but it's still a lot of weight over a small area, so it can be painful.
And this one's more patient specific, so I will let you, Kathleen.
Okay, Tracy asked, she said, I'm scheduled to see you in December
Great.
to see if it's needed for me. Dr. LaRose referred me due to bone on bone and a lot of pain. Would you decide at that time, I think is what she means, if I need it or not, and how long are they scheduling out due to COVID? It's very specific.
Yeah, well, yeah, I mean, I'll be happy to meet you at that time, and we can go over everything and see if it's going to be appropriate. And if you feel like you're ready, yeah, we're still, you know, in this pandemic, and it's, you know, we all want to be out of it. But all the hospital numbers have been improving over the last couple months. So we haven't had to shut down these elective surgeries recently, and hopefully it stays that way.
So I really did enjoy your presentation, and I know that you mentioned that you should kind of exercise. What kind of examples would you consider for low impact exercises that people can do to prevent or gain some muscle there?
Yeah, so you know, in general, just lower impact exercises include like closed chain type exercises where the bottom of your foot is supported throughout the arc of motion. So things like riding a bicycle or stationary bike, or even an elliptical, excuse me, is better on the knee joint versus running on a treadmill, because every time you lift your foot off that belt and come down, it can cause you know, pain and impact on that joint surface. Pool exercises are really good to do as well.
And what about weight bearing exercises?
Like resistance type of training?
Pretty much, yes. Anything with weights.
Oh, okay. Yeah, again, you can do anything you can tolerate. Bending the knee more than 90 degrees, especially if you have pretty significant arthritis, can be very painful. So I usually tell people try not to bend down too much. Like if they're going to do a squat, try to keep it at 90 degrees, because if you go lower, again, it's just a lot of pressure in that small area.
And I know during your presentation, you were talking about metal versus non-metal. Why would a person get a metal versus non-metal?
Yeah, good question. So there have been some concerns of metal allergy in the past, but these days we don't worry about it as much. Detecting a metal allergy inside the joint itself is very difficult to do. An allergic reaction on the skin is not going to be necessarily the same in the joint itself. We just don't have really good ways to test for these allergies. But you know, it used to be a bigger concern like 10 years ago, but nowadays it's not, you know, not as big of a concern.
Such a fascinating presentation. We still have a few more minutes if anybody wants to go ahead and ask a few more questions on the Q&A. I gotta say, I did look at your slide, and was that a Doctor Who robot in there?
It was, yes. I kind of skipped it, but yeah. When I was looking at all the different types of robots that are used in these knee replacements, it kind of reminded me of a Dalek. And Dalek is not a robot; it is an alien species in this Doctor Who series.
And if you haven't seen Doctor Who, it's a good show. I recommend it. I highly recommend watching Doctor Who.
Dr. Jahng, I wanted to ask, so after a person's had a total knee replacement, what kind of activities would you suggest they not do? Is there anything that they would do that might decrease the life of their new knee?
Yeah, in general, high impact activities can cause some problems potentially. The implants are pretty durable, but one of the most common reasons for failure is going to be loosening of the component. So if you engage in high impact activities frequently, then there is that increased risk that you can have loosening of those components. So in general, you should probably, we usually recommend avoiding some of those activities.
We have a few more questions here. John said, how would you compare total hip replacement to the knee replacement in terms of pain and recovery?
Yeah, in general, people recover faster after a hip replacement compared to a knee replacement. There's just a lot more motion in the knee joint, and it's more complex. So overall, people experience more pain. But they get through it, and that healing pain is temporary. And once they have recovered, again, most are do better after the surgery.
Now, you said there's a question, can you run after total knee replacement? Would that be one of the high impact exercises you're talking about?
Yeah, I mean, it kind of depends on who you ask. There's going to be some surgeons that will recommend you don't run at all, and others they go for it. So it kind of depends on the patient and also what the surgeon recommends. So I would ask, the surgeon that's actually doing the surgery.
John wants to know, if you need both knees done, how far apart would you do them?
Good question. I get this question a lot. I think it just depends on the person. I've had some people that go through one side and they want to wait a year or so to get the other one done. But I've had other patients that want to do it the next month or two.
I think Colleen had a similar question, and I just wanted to say, Colleen, I think he just kind of answered the same thing.
Is there a maximum age?
Again, I think that depends on who you talk to, but I tell people, age is one thing, like chronological age, but I think physiologic age is more important, just how your overall health is. If you are healthy and ready to, go through that whole process, then I think it's okay.
Tracy wants to know if you can do both knees at once.
Some people do. Yeah, bilateral spontaneous knee replacements can be done. Usually I recommend doing it staged, one at a time, but in certain scenarios, two can be done at the same time. It is a harder recovery. There's the surgery itself would be longer. There's going to be some more blood loss. So really, it would be more appropriate for that younger individual that's healthier, doesn't have as many medical problems.
How soon after knee replacement do you start outpatient physical therapy, and how many times a week should you be going?
I always tell people as soon as possible. I want them to be in within the first week, and I want them to move in the knee. But even before they go to that first appointment, we give them exercises here to do at home from the get-go. just again, regaining that range of motion is very, very important. It takes time, it takes a few weeks, but I usually tell people I want them to have that full motion by 6 to 8 weeks.
And I think most physical therapy, you go twice a week. Isn't that correct?
Yeah, usually twice a week. If people are kind of struggling to regain that motion, I'll bump them up to about 3 times a week if needed.
I don't think we have any more new questions. Tracy just has a statement. Thank you so much for your wonderful presentation. See you soon.
We'll see you. Thanks for joining us.
Well, we are ending a little bit early, so if there's no more any more questions, we'll definitely start ending a little bit early.
Sure. And I wanted to just say, how can patients contact you if they want to schedule an appointment with you?
Yeah, they can call my office.
Is it Arrowhead Orthopedics?
Yeah.
At 909-920. No, I think it's 91. Oh, sorry. Yeah, I'll look it up.
I should-
I should have looked before I said.
09-912-1750.
Okay, thank you.
912, I'm so sorry, I'm putting this in the chat.
909-912-1750.
I had to think about it. We have a few offices, so that's for
Is that
our
correct?
actual office.
For all of you, I just posted it on the chat if you want to make an appointment. And I think we have a few more questions. Here we go.
How soon after knee replacement? Nope, I already read that
We read
one.
that one. We were right here. So
Got a
John,
question.
John says, you did my wife's hip replacement and she is still thrilled with the results. Thank you.
Oh, you're very welcome. Excellent. It's good to hear.
Tennis and hiking. What about tennis and hiking?
Yeah, I think it's reasonable to return to those activities. With the tennis, maybe doubles is a little bit easier on the knee.
And John also asked, what is the shortest recovery time? I'm sorry, Mark asked, what is the shortest recovery time?
Well, again, everybody's going to heal a little bit, different. I have some people that regain that motion really early on. But as far as wound healing, the wound is pretty, the skin heals within two weeks. The deeper layers will heal pretty well within 6 to 8 weeks, if not a little bit sooner. But everybody has a different timeline.
And then Jerry said he was watching a Satco Kings game, and they mentioned a player had a knee replacement and playing again. How was that?
It may be possible. I don't know the details of what type of knee replacement it was. But yeah, a lot of people can resume most activities after the surgery.
Colleen asked, do you come to the high desert?
I myself don't go up to the high desert. We do have an office in Victorville, but we also see some patients down in our offices in Rancho Cucamonga and in Chino Hills.
I think we got them all. Yep, I think we got all the questions. Well, thank you so much for joining us today. I totally forgot to mention who I was earlier. So my name is Roxana Robotic, and I'm the Community Health Supervisor at San Antonio Regional Hospital. And I just want to thank you all again for joining us on tonight's community lecture. Thank you so much.
And thank you. Thank you, Dr. Jahng.
Thanks.
Great.